of Psychiatry.
Oh, no. I didn't.
Hello, everyone. I'm a professor of psychiatry at Rutgers Robert Wood Johnson Medical School. And thank you for joining us today on this webinar on using policy change to address tobacco. I'm also the medical director of the New York City TCTTAC program. Please remember to mute your lines. As we go through this webinar, you will have an opportunity at the end to ask questions. So thank you so much for joining us. Hopefully you're familiar with the TCTTAC project. This is an initiative of the Department of Health and Mental Health, Bureau of Mental Health, which is a partnership with CPI, the Center for Practice Innovation at Columbia. This program is approved for continuing education credits. However, keep in mind you must also attend part 2 of the webinar series on environmental changes on Thursday, June 10th at 2 p.m. in order to receive credit. So our learning objectives for today are to understand how policy change supports treatment for tobacco use disorder. We'll talk about the different components of a comprehensive policy and how you might begin to think about implementing such policy, and also the benefits of policy change as part of an overall initiative for addressing tobacco in your program. Before we start, we'll do a quick poll just to check in with people today and see where you're at in terms of addressing tobacco. So our question for today is, on the physical grounds of our treatment program, the use of tobacco is either not allowed anywhere, you must leave the property to use tobacco, allowed only in designated smoking areas, or tobacco is allowed anywhere with no restrictions. So take a moment and respond to the poll. Please remember to mute your lines if you're just joining us. Okay, we can see our poll results. Okay, so a lot of you reported that tobacco use is not allowed anywhere. You must leave the property to use tobacco. And a lot also say that it's available in designated smoking areas, and very few of you, only 4%, say that it's allowed anywhere with no restrictions. So as we focus on policy today, you might be asking yourself, why think about policy to address tobacco? Well, policy is a highly effective strategy that has been studied and used for years, and we know has a broad impact because you have the ability to reach all populations with this effort. It's highly cost effective. It usually doesn't cost so much to implement a policy. And again, it is shown to be effective. So it is an evidence-based strategy for tobacco. One of the things policy does is it changes the norms and the social acceptability of tobacco. So anything that makes it harder to use tobacco in this environment can be an effective component of an overall policy change. We know that when there are policies in place that restrict tobacco or even forbid tobacco use, it reduces youth uptake. So fewer young people will start smoking as a result of policy. Policy also has the opposite effect of helping adults, increasing the motivation to quit. So how does policy work to address tobacco? Well, again, there's lots of different components of this. You could think about policy affecting the environment of care. Again, most policies, the overall mission in some way is to restrict access to tobacco. Again, we have many of these examples in New York, policies that restrict access to smoking or restrict access to secondhand smoke. This can be seen as reduced smoking areas, tobacco-free physical space, even prices, raising the price of tobacco, and taxation. It indirectly restricts access to tobacco, and in particular is a very effective strategy for young people who do seem to be price sensitive. So anytime the taxes are raised on tobacco products, that's a really effective strategy for reducing tobacco use overall, and is highly effective in young populations. You can also think about writing policies that influence the treatment environment and increase access to treatment. This can be done through education. Your policies can set minimum standards for treatment for your facility, and also define roles of different professionals in participating in the tobacco treatment plan. So there's lots of different ways we can think about using policy to shape our initiative. Policy is a key component of our overall approach that you may be familiar with. I'm going to speak a little bit about just sort of the big vision that we have laid out for how you might think about implementing these different kinds of changes at your behavioral health program. One of the steps in that process can include doing a self-assessment of your program, sort of a snapshot. Where are we today in terms of implementing tobacco treatment at our facility? It allows you to evaluate your program in different domains and receive feedback, which may be helpful as you're planning sort of next steps or trying to prioritize which would be the most helpful things to work on. And one of the components of the overall plan, and one of the domains then included in the self-assessment, is thinking about this area of changing policy and working with administration. And that's really our focus today. So if you're thinking about implementing comprehensive policy for tobacco, these are the kinds of things that you would generally want to include. You often want to include some kind of statement of your purpose or rationale for this policy, perhaps a mission statement around tobacco, in thinking about the organization addressing wellness or increasing people's mortality, sort of reducing mortality and morbidity, and improving quality of life. Again, you can typically have sort of a clear policy statement that kind of addresses the who, where, when, how. You would also want to include the definition of tobacco in your policy, all the things that you want to address, and being inclusive and specific about that. Your policy may have responsibilities, for example, who's going to be responsible for different components, how might you communicate that with your stakeholders, with the public, with the clients you serve, and how will these policies sort of affect people like different groups, like your employees, your visitors, or your clients. And each of those could be defined specifically within the overall policy. Again, the goal is to change the norms, the rules, and the standards of behavior as a way to really support what you're doing in terms of increasing treatment. When I think about interventions for addressing treatment, we want our treatments to be more effective, and we want to deliver evidence-based treatments, but we also want to increase the demand for treatment. We want more people interested in these kinds of tobacco treatments, and policy can be really helpful in thinking about that component. How do we increase the demand for services around tobacco? And we think about that in terms of changing the norms of behavior. So for example, we're going to talk about having tobacco-free treatment grounds, no tobacco allowed at the facility at all. But for many programs, that can feel like a big step, and perhaps not the step that they want to pursue initially. But you can think of alternative kinds of steps, like maybe we shouldn't smoke together. The clients and the employees maybe should not be using this drug. It is a legal drug, but it's still a drug, using this drug together. And that's the kind of behavior we want to begin to segregate and think about, and have our staff and employees really support healthy living wherever possible. So that's sort of perhaps a smaller step in terms of policy change that can often be implemented fairly quickly. Another example of a policy change would be to define the minimum standards for treatment. So for example, you can write policies that say things like, we're going to assess everybody for tobacco use, or we're going to conduct carbon monoxide readings and give people feedback about carbon monoxide on every new intake or admission. So again, you can do that without a policy, but when you do a policy, it really helps to sort of make the practice more systematic and sort of increase the enforcement that people are actually going to do it. Again, changing the norms of behavior within the program. You can have policies that reduce people's exposure to deadly secondhand smoke. We know that secondhand smoke kills people every year who are not tobacco users themselves. And many employees in behavioral health may be asked to do home visits. And so the agency should think about having policies that say that employees should be protected from smoke exposure during home visits. It seems sort of obvious to me, but it's quite common that this is not a written policy for many organizations. And I think that everyone deserves to breathe clean and smoke-free air. And it certainly is also a worksite issue, that work sites are generally protected. And so, but it's nice to have sort of a formal policy so that everyone sort of has the same rules and again, establishes the minimum standard. Another impact of policy is that we know that it results in increased tobacco treatment. So this is an example of statewide policy in New Jersey that was directed towards addiction treatment programs. And when the policy went into effect in 2001, you can see that by 2002, there was a big increase in tobacco treatment that was driven by this policy change for tobacco-free treatment grounds. So for example, assessment and counseling, training of staff, all of those measures went up as a result of this policy change. So sometimes the policy change creates a sense of urgency that gets people more interested in working on this issue. It also, of course, you don't want to be restricting tobacco without having lots of treatment services in place for people who are addicted to tobacco. This is just another example of how policy to implement training also increases treatment. So training can be another component of changing your program, getting your staff educated on evidence-based practices. And we know that implementing training also results in staff providing increased treatment services to their patients that they serve. So you can have policies that say, we're going to get everybody trained in evidence-based practices for tobacco as another way to affect change. Certainly the biggest step would be to think about tobacco-free treatment grounds. That's sort of the gold standard. And it's always better, even in just thinking about language, to talk about tobacco-free as opposed to smoke-free settings, because you really want to be inclusive of all kinds of tobacco products. If you just say that you're smoke-free, then people might interpret that as it's okay to use chewing tobacco or even e-cigarettes. And really, you want to strive for the best example of this, which is tobacco-free. And again, in your policy, you can say, we define tobacco as, and you can include things like electronic cigarettes, smokeless tobacco. You can even include paraphernalia in your definition of tobacco and how you want this policy to be inclusive in terms of the broadest reach. Again, tobacco-free generally means not only inside of the buildings, but also outside on all the associated property or the grounds. Generally, these policies apply equally to both the clients as well as the staff. And just to give you some sample language that programs have considered in this kind of tobacco-free initiative, this is just one example of language saying staff shall not use alcohol, tobacco, or illegal drugs during working hours or when representing the facility. That's sort of one way to do it. There's many ways that you can craft the language to meet your needs. Other options might be to use language like staff may not be identifiable as tobacco users. You don't want to, tobacco use may not be visible from the property. And sometimes places consider different timeline for implementation for the staff and the clients, because often you can implement a more restrictive environment for the staff at an earlier date while you're still working out how best to do this with the client population. The idea that you have policy that says things like you can't be visible from the property can be really helpful in an urban setting where you don't necessarily have a large physical grounds and people just go down, off the curb and they say, well, now I'm not on your property any longer. But if you really want to have the greatest reach, you can say, well, we really don't want to see you from our property. Again, having people really leave the property, maybe go a block away, in order to really comply with the aim of the policy. Some of this may seem surprising or new to you in terms of this idea of restricting tobacco use by staff or employees during work. But it's actually fairly common nowadays outside of the behavioral health setting. This is an example that I came across, a real policy from the local medical hospital in my own community in New Jersey, where the employees may not smoke on the hospital premises and during work hours, and that the smell of tobacco smoke on clothing is not permitted. So this is fairly standard kinds of language. It's very reasonable to do this, to restrict tobacco use in the environment. This is a legal drug. We restrict alcohol, another legal drug, during work. So it's okay to do this, especially when you're in the business of healthcare. When you're in the business of healthcare, it's always the right thing to address tobacco. So we might think about a continuum of sort of staff behavior and thinking about policy change. So the most extreme example, many of you said you don't have this in place today, but might be no restrictions on staff smoking. They can smoke whenever they want and wherever they want during the work day. Another step towards tobacco-free might be to say, well, we're not going to go tobacco-free, but we're going to just limit that we can't smoke with the clients. We're going to separate that behavior between the employees and the clients. The next step might be to say, well, employees can use tobacco during work, but they really have to leave our physical campus and be off campus. A next step might be to say, well, really now people can't use tobacco at all during their work period. If a place were to go completely tobacco-free, they might want to, in the future, create a policy that says that they only hire non-tobacco users in the future. You can imagine that that makes sense. If you're going to have a tobacco-free environment, it doesn't make sense really to keep hiring people who are using tobacco to work at your facility. Now, that is to say that you don't want to punish the people that already work there, and certainly that would be discriminatory to do that. But you could establish standards that say we're not going to continue to hire people that use tobacco in the future, since we have a tobacco-free standard, with the ultimate goal, of course, being that everyone is tobacco-free in the environment. And just to show you, there are corporations and healthcare organizations already that have policies like these in place, where they have tobacco-free campus pretty strictly defined, and they do not hire people that use tobacco. So that is considered legal, and there is at least some precedent for that. Again, it feels radical to us in behavioral health because we are really not as far along as the rest of healthcare and the rest of society in many ways in addressing tobacco, but this has happened in other industries. Again, the message is not punitive. It's not about punishing people. It's really telling the employees, we care about your health and we want you to be healthy and optimal in the work that you do. So it's really a positive message. We're in the business of healthcare. We care about everyone's health. We care about everyone's tobacco addiction. So it doesn't have to be a negative message, certainly. So when we think about policies, specifically thinking about staff behavior, so if we're trying to really transform our organization and we're implementing tobacco treatment, and we're thinking about how can policy be helpful to change people or to support the treatment initiatives that we're doing, Again, you can have policies that say things like we restrict tobacco use at work in the workplace for staff, but there's other examples that we can think about as well to sort of shape behavior and support our other initiatives. We can write policies that say that the staff don't take clients to buy tobacco. In New Jersey, it's not that uncommon that a case manager or some staff might actually transport a patient at times. And and maybe not think that it's so unusual to drive someone to a convenience store to buy tobacco. However, I kind of raised the issue that if we're not taking people to the liquor store to buy alcohol, another legal drug, we probably shouldn't be serving that role for tobacco. So we actually could define that at an agency level, that that's not something that we do, that we sort of transport people to buy drugs, in this example, the drug of tobacco. We also could do more in terms of the continuum of care and discharge planning in terms of policy and program intake. When you think about people who are hospitalized, these are often tobacco-free settings. I know that that's true for much of New York, that someone's having a tobacco-free experience while they're in the hospital. And so we won't really capitalize on that as much as we could in terms of helping people to link to the outpatient setting and providing a continuum of care where sometimes people may be able to maintain that benefit that they achieved in the hospital, and really having it as part of discharge planning, continuum of care, addressing it at program intake, so that we're really helping people through that transition, providing them with access to, say, nicotine replacement. But it's just an example of a policy change that can really help, again, to promote this overall treatment initiative. We could also think about policies that are directed towards peers or peer counselors to either support, encourage them to stop using tobacco, or even to incentivize them. I think that the peer workforce can be really a highly effective a place to think about sort of disseminating a tobacco education message, but it's certainly going to be more effective if those peer counselors themselves have been successful in their own recovery from tobacco. So is there a way to use policy to sort of address different populations or incentivize different groups? So why should we think about this idea of tobacco-free treatment facilities? What's the goal? What's the idea behind it? Well, in the olden days, right, we used to reward people's behavior with cigarettes. We provide smoke breaks within the context of our treatment day, which really is promoting using drugs for coping in certain ways. We don't do that with other substances. So as much as possible, thinking about sort of getting away from that past way that we've structured some of our services. We want to provide a consistent message that if we treat other addictions, we should treat tobacco addiction in keeping with our overall mission. We could argue that having our facilities be tobacco-free gives people the greatest access to treatment in terms of medication and counseling, and is consistent with our other goals for wellness and recovery. Unfortunately, people start using tobacco in the mental health treatment setting and the addiction treatment setting. We hear that from patients time and time again. And so we want to perhaps remove that issue, at least for young people and young populations. Certainly people also relapse back to smoking during a treatment episode. If everyone in the environment is smoking, you can imagine how easy that would be to happen. We talked about how it's a workplace issue. And again, we are in the healthcare business. So in healthcare, it's never considered radical to think about adopting tobacco-free strategies. There are obstacles, certainly, and barriers that sometimes make this challenging. People have studied this, especially through the NASHBID Institute, which is an organization of state mental health program directors and other leadership at the state level. And what these groups have found is that over time, the most common obstacle to change is the staff. Interestingly, it's often not the clients. The staff really fear that the patients will adversely react to policy change. So although there may be some pushback from patient advocacy groups, it tends to be that the greatest forces against change come from the staff. And it's not just staff who smoke, but sort of this general resistance and fear of change, which can sometimes stall the initiative. When facilities go through the process with planning, many are shown to be successful. And often when you interview those staff after the implementation of the policy, often the staff reflect that their initial concerns really didn't happen, that there's many advantages that they now see in the facility, that the health of clients improves, that the grounds and environment are cleaner, that there was often concern that there'll be behavioral disturbance related to this, and that doesn't really happen, or in fact, sometimes incidents actually go down. There's more time for treatment if staff are not having to deal with tobacco. Staff often say that they're more satisfied when these kinds of policy changes are implemented. And many studies have shown no negative impact in terms of patient behaviors like violence or acting out. So nowadays, it's pretty common for people to talk about these kinds of policy changes, and just to show you that at the federal government level, this has been widely supported. So for example, now on every SAMHSA grant application, which is of course the greatest source of funding for the states that comes through the federal government, SAMHSA grant language includes this language that SAMHSA strongly encourages all recipients of funding to adopt a tobacco-free facility grounds policy and to promote abstinence from all tobacco products. It doesn't say that it's required at this point, but it may move towards that requirement over time. And so for now, the language is that it's strongly encouraged. Again, it's just evidence of the change towards wider adoption of these kinds of policies. We used to sort of lobby for exemptions. So if the whole hospital was going tobacco-free, often the psychiatric unit or the mental health clinic would be exempted from the hospital tobacco-free policy. But we do not want to ask for exemptions at this point, because that's really worsening health inequities in people with mental illness and really stigmatizing people with mental illness by saying, you know, sort of everyone here in this hospital or healthcare system can benefit from clean indoor air and tobacco-free environments, except those people with mental illness, which is really, again, a form of discrimination, bias, and stigma. We should argue the opposite, that clients with mental illness really deserve the same protection from tobacco exposure that benefits the rest of the public. What about smokers' rights? People get concerned, you know, will we be sued? Don't people have a right to smoke? And I want you to know that certainly some of these cases in US history have gone to court, but almost always the courts have found for the side not for the smokers' rights, and have deemed tobacco not to be a right, but a privilege that can be restricted when it's detrimental to others. So there's really not much legal precedent for smokers' rights. It's just something that's been, in fact, supported by the tobacco industry, but really doesn't have much legal standing. So for example, if the courts have found that if somebody is in a supervised treatment services that's paid for by public funds, like smoke-free, like public housing or psychiatric hospitals, they can in fact legally be tobacco-free. Sometimes programs are sort of unsure about taking that step, about being tobacco-free. And often there's sort of debate about whether or not we should have designated smoking areas at our facilities. And I think there's sort of pros and cons for thinking about having a designated smoking area at your facility. Sometimes there are safety issues in terms of there really is nowhere for people to go, and that can be a concern. It can be helpful if there's concern that there's going to be disturbance to neighbors or neighboring businesses. And it sort of feels sometimes compassionate, like the right thing to do. However, we could argue it the other way, that it's continuing to allow the behavior, and in many ways is enabling sort of this addiction and substance use and using drugs to cope with mental illness, which really is opposed to often what we say our mission is as a program. It doesn't really help to change the culture. There continues to be sort of litter and sort of a dirty appearance with a lot of cigarette butts. Sometimes the employees complain that smoke comes right through the window into their offices, and there's exposure that way when people are smoking right outside of the building. If some people are actually trying to work on this addiction and quit, it can be very triggering for them to have to pass through a whole group of smokers, essentially to go to their treatment visits and appointments. So then the environment really gets to be associated with smoking and is not seen as a safe place to avoid tobacco use. So again, drug availability then is a feature, and that's unfortunately what's true, that people associate that their program is where the tobacco is, rather than being a safe place that supports treatment. Are there negative consequences when programs implement these kinds of changes? Again, this has been studied widely, both in psychiatric as well as specifically substance abuse settings. And time again, it's found that there is no increase in disruptive behaviors among the clients. There's no increase in AMA discharge. So people don't leave treatment just because treatment is tobacco-free. Clients actually support that they're interested in tobacco treatment or addressing tobacco during their treatment for their other behavioral health conditions. And many studies have also shown no reduction in admission. Sometimes there's a concern among the staff that people won't come to treatment if the facility is tobacco-free. But again, many places have shown that that is not the case. The best example that I always show, in fact, comes from New York, where the OASAS system had an implementation of tobacco-free treatment in all substance abuse facilities, inpatient, outpatient, methadone programs, more than 1,400 programs. And this went into effect in 2008. And within that system, they were able to track admissions to substance abuse services throughout the state of New York. And you can see that admissions in 2007, 2008, and 2009 virtually stay the same. So it's not true that when this policy was implemented in 2008, that there was a reduction in admissions to substance abuse services. It's not true that people won't come to treatment because of this. But again, you can see that in many ways, New York did it the best way, because these policies are going to be most effective when they're done on a large regional or statewide basis. Because obviously, if your program goes tobacco-free and your competitor a block away is not implementing this, it can create sort of an unequal playing field. And so doing these policies at a regional or statewide level is really best for everyone. And unfortunately, we know in this country that even with increased recognition of the problem of tobacco use among people with behavioral health conditions, we know that even 20 years later, since I've been doing this work, that there's still limited access to treatment for tobacco in the behavioral health setting. This is a fairly up-to-date report done by the CDC with data from 2016, which shows that, in mental health treatment facilities, less than half of the people even get, less than half of the time are we even screening people for tobacco. So if we don't ask about tobacco, we're much less likely to do treatment interventions. You can see those are also low, and the numbers are similarly low in substance abuse treatment facilities. What was really nice about this report that the CDC published, and there is actually a more up-to-date version that was recently put out, but they provided state-by-state data. So for example, on the question of what's the percentage of facilities in your state that has essentially tobacco-free treatment grounds, New York did rather well, higher than the national average in both mental health and substance abuse treatment facilities. So New York has really been a leader in this area of developing policy and does better than the national average on this. And again, it's not really that new anymore, because lots of states have implemented statewide policy in at least parts of their behavioral health treatment system. So it's not that uncommon Most of Texas is tobacco-free in terms of its large behavioral health system. Entire cities like Philadelphia went tobacco-free, which also included their psychiatric hospitals and behavioral health services. So this is not so radical anymore and is really being widely adopted. In Philadelphia, for example, they studied their implementation process, which happened fairly recently in 2015. And when the whole city went tobacco-free over a period of about a year, it included 14 inpatient psychiatric facilities. And they were able to show that really there was no negative impact on the patients in terms of admissions to treatment did not go down, incidence did not increase, although the overall use of nicotine replacement was a little lower than they expected. A key part of thinking about policy is really including the leadership in this discussion. Obviously, these decisions come from the top and with an administrative buy-in, and having administrative leadership helps your tobacco initiative to be much more successful. Big changes require leadership and support and really are critical to the success of the implementation. Sometimes there's a champion sort of on the ground who really is trying to do this at their institution, which is really a wonderful thing, but it's necessary to bring in a group of people and certainly have administrative leadership and support to be most successful. In fact, this is seen as a common mistake in any kind of organizational change, not including leadership. If it's unclear who's sort of leading the effort, it can often sort of fall apart. People become frustrated and disillusioned and it doesn't move forward. As well as some modeling in the leadership, sort of really supporting publicly the initiative, being willing to change their own mindset, et cetera, in keeping with the changes that are being asked of the organization. So these are sort of key components in terms of getting buy-in and helping the policy implementation step to be effective. As I mentioned, we sort of see this as an overall a model for implementing change and increasing access to tobacco treatment at your agency. We have several tools now that we've developed that go through these steps and show you sort of the big picture for how you can think about this work. We have a document which is sort of the steps to think about if you're going to create an overall plan for addressing tobacco in your program. You might want to complete the TCTTAC, which is the self-evaluation tool to sort of evaluate where your program is at this moment in time. If you do that and submit that to Nancy Koval, she can provide you with a really lovely report based on your self-evaluation. You can use the results of that report to strategize and prioritize what you'd like to work on at the agency and develop a specific implementation plan. And then we have a document that also sort of maps onto the different domains of the TCTTAC and says, well, if you're really wanting to work on policy, here are some key tools and resources in the roadmap that can help you to do those next steps. And as I mentioned, working on policy and administrative issues is part of the plan and is one of the domains of the TCTTAC, because we know that written policies are a highly cost-effective strategy to address tobacco use and to change the norms around tobacco in the environment. Another aspect of this, which I didn't really talk about today, is being able to evaluate and measure your work so that you have evidence that it's working and you're able to track it over time. So we're about out of time, but we certainly have some time for questions. I'll tell you that everything we talked about today is available on our website. So that's a resource where you can find many of the tools that I described. I know there's one question here in the chat, which I can address, and certainly I would encourage you to include questions in the chat if you'd like me to address them, or we can have a few moments where people ask their questions out loud. We have a few comments about the issue of hiring only employees that don't use tobacco. And I do recognize that that's a few steps out from where we are, and it does feel radical. Even when I mention it, I know that it's going to feel that way to people. I'm not suggesting even that we necessarily do that or include that. That would be a step that would be pretty far along in the process. There's a comment that it doesn't just seem radical, but it seems intrusive and bad for mental health, not hiring someone who uses tobacco outside of work. It shouldn't be the employer's business if it doesn't affect their job. And I think that that's not a bad statement to make. I mean, that's the way we view the use of other legal drugs, that if it's not impacting, it certainly can be restricted at work, which I think is really the key point, that you can certainly restrict the use of this legal drug in the workplace, and you can shape behavior of employees while they're at work. And you can certainly make the argument that when people leave work, they're free to do whatever they want. And if it's not impacting work in any kind of a negative way, that that's really an okay thing. And so I don't disagree with that statement. I think one of the challenges is that the way that this drug is used is that most people are not just occasional users of this drug. So, you know, in the way that people can be occasional users of alcohol, this drug tends to have much more of an everyday usage pattern. Most people who use this drug are in fact addicted to this drug. And so we can say, well, people can use tobacco whenever they want, but just not at work. But in reality, that can be challenging for people who are actually addicted to the drug. So I think that's sort of the spirit then of saying, well, people really need to be free of the drug. But I certainly do understand that point of view. An alternative strategy might be to say that if we're going to have a policy like this, that's very prohibitive in terms of what employees can do in the workplace, and we're not going to allow them to use any tobacco. I certainly think we could do a whole lot more to incentivize people and to be sort of humane and compassionate about that kind of a policy and offer employees free nicotine replacement. For example, it wouldn't be unrealistic that employees could use nicotine lozenges during the day at work. And it would be wonderful if programs could actually supply that for their employees. And then people could always choose to smoke when they left work in the evenings. And so that would be sort of a workaround, one way to sort of meet all the different kinds of needs. So I don't know if there are any other questions or comments. We have a few minutes. David, I see your comment about motivational interviewing, and I don't disagree with you that it's a highly effective strategy. We should all be using motivational approaches in all that we do. I know sometimes these policies feel strict that way and not consistent with all of the work that we do in terms of engagement and motivational interviewing. I'm not sure I completely understand the question though that you put in the chat. So I would welcome you to, if you want to unmute yourself, certainly you could ask this or raise your comment if you would like to. Something else I would say about policy is that, you know, these policy changes always feel challenging in the beginning. Certainly, I remember when New York went tobacco free for bars and restaurants, and it always feels like it's not possible. Or in the housing situation or on transportation, airplanes, it always feels like it's challenging and it can't possibly work. And the truth is that we all do adapt, we do change. And these policies are highly effective in terms of reducing overall population use of tobacco. So we certainly want to be helping our patients in any way possible and supporting them through changes. But it is one effective strategy for thinking of an overall approach for addressing tobacco. Before we wrap up, anyone is welcome to ask a question. If you'd like to unmute yourself, I would certainly welcome that.
Jill, this is Rusty. I just have a very kind of short question, but so people came to this and said they all want to do a policy change. What would be the next step that you would recommend for people to take? I don't know how many people are administrators, policy, you know what I mean, where they're at in their agency.
Well, certainly I think that this would be best suited for a work group. So I think probably having a work group or bringing together some group of people to discuss the different options would probably be the next best step. There isn't going to be one policy fits all sort of approach. It's going to be highly tailored to the site and the needs and the patients that are served, as well as just sort of what the goal of the policy will ultimately be. So I guess the next step would really just to be to form a work group and begin to sort of work through some of those issues at the local level. We can certainly provide resources, examples of policy documents, et cetera. So again, I do think it's a complicated issue. I see the comment about really encouraging people to work, have meaningful lives, not to reduce people's opportunity because they use tobacco. And I do recognize that's a very reasonable point of view, to give people incentive, to be motivated, to have a better life and be able to work and succeed in life. And maybe that helps people gain motivation to quit. So, you know, I certainly believe in working with people wherever they're at, and I understand that. But I think just the other side of that is that, you know, most of society has sort of adopted a lot of these ideas. We're sort of the remaining group that hasn't. And I think that's just worth at least a discussion for us to be thoughtful about in terms of keeping up with the community standards. So thank you everyone for attending today. I appreciate the questions. I hope it's been helpful, and we will follow up with part 2 on Thursday at 2 p.m.